this week on the BackTable podcast.
That's exactly what we're trying to do now in research is we're trying to do a combined approach where we operate endoscopically, laparoscopically, and vNOTES with two surgeons at the same time for radical endo, because what is the most difficult is from above is the lower part. If the nodule's low down on the rectum, halfway the vagina, it's difficult. If you come from below, that part's not difficult endoscopically. It gets more difficult as you get higher and higher. And if you use the best of both worlds, you can meet each other in the middle. So that's what we're trying now.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and we have Dr. Jan Baekelandt from Belgium here with us today.
Thank you for having me, Mark.
No, it's our pleasure. And we're here to chat about vNOTES. And as we do at the beginning of all of our episodes, tell our listeners a little bit about you, where you practice, and how you became interested in vNOTES.
So I'm based in Belgium, just north of Brussels. I work in a sort of medium-sized hospital where I work as a gynecologist. But because of our setup in the department, I ended up doing a lot of benign surgery as well. So I'm basically a general gynae surgeon with a focus on gyne-oncology. That's Imelde Hospital in Baekelandt. I have affiliation with the University of Leuven in Belgium as well. And I have a little research affiliation with the University of Lund in Sweden. But I mainly work full-time in Imelde in Baekelandt.
Tell us a little bit about what vNOTES is, what exactly that means, and what that surgery is.
So vNOTES is it's a complicated term just to say that we're doing laparoscopy through the vagina instead of through the abdominal wall to make it easy. So vNOTES stands for Vaginal Natural Orifice Transluminal Endoscopic Surgery. It's an acronym because we operate endoscopically through the lumen of another organ, so not directly through the abdominal wall, via natural body orifice. And for gynecology, it makes sense to choose the vagina as the natural body orifice of choice to operate through. But there's other types of natural orifice surgery. You can operate transorally, you can operate transanally. The colorectal surgeons do TMEs and Thomas procedures transanally. But for gynecology, it makes sense to do our natural orifice surgery transvaginally. So basically what we do in vNOTES is we do pretty much all gynecological operations by now without making any abdominal wall incisions. So the entire procedure is performed transvaginally, and we do this endoscopically like we would operate laparoscopically. With the same instruments, we insufflate the abdomen with CO2, but we use all those instruments transvaginally.
It makes sense. I think in my own training, I'm a MIGS surgeon, and so I do almost everything laparoscopically. And I trained at an institution where they had strong urogynecology, so we didn't get a ton of vaginal surgery. Vaginal surgery in general is one of those things that I think in our training seems to be, we have a harder time teaching that, I think, than we used to. And while it's great that we're adding robotic and laparoscopic surgery for our patients, it doesn't seem like we're maintaining the level of vaginal surgery volumes to help a lot of us get comfortable. So personally, it's something I don't do very often. But is that something you've always continued to do? Is it something with vNOTES that you reintroduced into your practice? Talk about how you got interested in vNOTES.
I've always done vaginal surgery. I was trained in benign vaginal surgery, and I had training in Schauter surgery, so the radical hysterectomies for cervical cancer to be done transvaginally as well. So I've always kept doing vaginal surgery, but vNOTES has now helped to really broaden the indications. And whereas in the past we probably did 20-25% of our procedures vaginally, we now do more than 95% of our cases vaginally. I started vNOTES more than 10 years ago, and I think 2012. But slowly, step by step, my old teacher, endoscopic teacher, actually was always in the habit when he did laparoscopic adnexectomies to remove the specimen transvaginally. So he always made a colpotomy. He taught me, at the end of a laparoscopic adnexectomy, make a little colpotomy and take the specimen out, not to have to make your muscle sheet incision wider in the abdomen. And at the time, I was going through a phase where I was doing single-side surgery. It was sort of 2011, 2012. And there was a bit of a hype on single-side surgery. I think it's sort of died down a bit because it's technically very, very challenging. And, there's not a whole lot of evidence on the benefits for it. But at the time, we were doing a lot of single-side surgery. It was with glove ports still back then. And it sort of made sense when we did a single-side hysterectomy. You could take the specimen out vaginally. When we say the single-side adnexectomy, we're taking the specimen out via a colpotomy. And then we sort of started placing that same port. Let's just have a look transvaginally when we've done that, made that colpotomy, and see what it looks like when we put the port there. And then sort of step by step, we moved forward and started doing more and more steps of the procedure gradually. It wasn't like one day of the other we started performing vNOTES cases. And that's sort of how it grew over time. vNOTES is not a new invention. I think the concept has always been there, and other groups in the world that have been working on that for a long time as well. I spoke to Lilo Mettler after a conference, and she used to work with Kurt Zem. In Europe, he's considered sort of the father of laparoscopy. And she said that Kurt Zem, when he was starting laparoscopy, and we're talking 40 years ago now, I think, he already had that idea that we should move from transabdominal laparoscopy, we should move to moving these instruments transvaginally. And they tried it at the time already. So that's now 50 years ago. But the instruments weren't right. The light sources weren't strong enough. Things weren't there. So it's not a new invention. It's just, I think, instrumentation got better. Our light sources got better. Our cameras got better. So we got to the point where we can do these things that actually the forefathers of laparoscopy already thought of a very long time ago.
I mean, I agree. It makes sense. I think there have been plenty of opportunities where I thought I did a TLH on this little uterus and probably could have been a good TVH case, but I wanted to take a look and see whether there was endo. I want to make sure I get the fallopian tubes, or if I'm getting the adnexa, it just becomes more challenging with the traditional vaginal hysterectomy. I think the barriers to many of us getting started, as at least I won't speak for everyone, but for myself, I'm not doing my colpotomies from below, right? I'm out of practice. I do 99% laparoscopic hysterectomy. So getting in from below, I get in from above. Was there any point when as you were developing these techniques where you were using a laparoscope, but also watching yourself from below to sort of see where you were? Because I think for me, I would have to kind of get a sense of like, what are my landmarks from below, and how does that relate to the landmarks that I'm used to seeing from above?
We all have a different threshold up to what level we're comfortable with doing. Let's talk hysterectomies vaginally. And some of us, the ones that have a big prolapse and they're basically hanging out, we feel comfortable doing that. And some very skilled vaginal surgeons will take out a 1.5 kilo uterus without prolapse as well. But I think we all have a different threshold as to where we decide we're going to do this vaginally or we're going to do this laparoscopic, speaking pre-vNOTES now. And I think many of us don't or didn't do as many vaginal hysterectomies as we technically could, because we've gotten spoiled with laparoscopy and robotics. We've got better hemostatic control. We've got these fantastic bipolar instruments and sealing devices that just give us better control. And we can see so well what we're doing. And I think that's the main thing, is when we're operating vaginally, a lot of things that could be within our skill set that we could be doing, we don't do because we just feel this little bit more confident in doing it laparoscopically because we know it's dry and we know we've seen everything well. And we just feel it's safer for the patient. And I think that's why many of us moved away from vaginal surgery for many cases into laparoscopic or even robotic surgery, just because of that confidence of visualization and hemostatic control. And that's now what vNOTES brings back. Now we can operate vaginally, which is the least invasive way for the patient, and have our patients recover quicker. But we can still have that hemostatic control and that visualization that we've gotten so spoiled with in laparoscopy. So I think that's actually what now vNOTES brings to the table and helps in broaden the indications for vaginal surgery again.
When you were starting out, was it primarily converted to if you did a case and you're like, I just can't figure out what we're doing here, was it a conversion to vaginal hysterectomy? Was it a conversion to laparoscopic hysterectomy, a combination of both? What was the learning curve like for you?
I think it's hard to compare vNOTES back then and now, because it wasn't an established technique. And, it was more of a very early on developmental curve where I didn't know really what the steps should be, and it wasn't standardized.
Almost let's see what we can do.
Yeah, my first hysterectomies took 4 hours via vNOTES. And, now vNOTES hysterectomies are significantly faster than laparoscopic hysterectomies. But at the time, it took me a lot longer. We didn't have good ports. We were making the ports ourselves. Now we have standardized ports that are approved for transvaginal use. So that sort of made it difficult because we were developing the steps of the procedure as well still. I think by now the procedure it has been for a long time now, it's been established. We know step by step what we should do. We know which instruments we should use. We know in which order we should be doing the steps. And that makes it a lot easier to do it now. As for learning curve of then an established procedure for somebody who has been trained in the technique and in a proper training setting, I think that also depends on your skill set beforehand. And I think one of the weaknesses of vNOTES is that you actually need a double skill set. You need to be confident in basic vaginal surgical skills, and you need to be confident in basic laparoscopic skills. I think for most vNOTES procedures, the laparoscopic skills aren't that hard because it's more grab and cut surgery. There's not a lot of need of retroperitoneal dissection. So I think if you have a basic skill set in vaginal surgery and in laparoscopic surgery, the adoption after proper training is quite quick. And most of the studies say 20 to 30 cases, but it all depends on how confident you are as a surgeon to start. I think if you have no vaginal skills or no vaginal experience at all, then your learning curve is going to be significantly longer. And vice versa. If you are just a vaginal surgeon with no laparoscopic expertise, but I think there's not that many of those around anymore, then it's hard as well. But I think with previous training in both, it's quite a short adoption curve.
We've recently gone through the training. We had the folks come down from Applied and do a course. So my group it's me and another big surgeon, and we have 2 urogynecologists that are in the next office over, next door, not in the next office building, but a close group who work together often. And we're just getting started. My partner's done a few. I've not even done one yet. So that's why I was excited to get you on. But having a couple MIG surgeons like my partner and I, who honestly, just most of us are not trained in vaginal surgery, even though we're supposed to be minimally invasive surgeons and TVH is the least invasive. Most MIGS fellowships are really laparoscopic robotic fellowships. And so our decision to start doing it had to be very systematic and safe. And we had to have the right people in the room, and having commitments from both Urogyn and MIGS is a great way for both divisions to improve their skill set, to be able to do more. And everybody wins, but it's been nice to have that partnership. But it is something that I think vaginal surgery and colpotomy is a bit of a lost art for some of us.
Yeah, it's always a huge advantage if you can start with more than one person in the department, go to the training together, go and observe with somebody with experience together, and then it's just easier to be two to get started. It's safer for the patient. I think that's exactly what happened over the years. Is teaching vaginal surgery, we're a bit less comfortable doing it because we don't see everything so well. But it's definitely a whole lot more difficult to teach vaginal surgery than to teach laparoscopic surgery because of that visualization issue. And I think with vNOTES now, it actually becomes easier to teach vaginal surgery again, because now you can see endoscopically what your assistant or your registrar, whoever you're teaching, is doing. So I'm hoping we're going to broaden the teaching of vaginal surgery again with this.
Yeah, it's when you get in there and see it, it is pretty incredible to watch, and you go, okay, that makes sense. I think there's going to be part of that learning curve is visual cues, and there's certain things I look for. Your brain just notices things when you do hundreds or thousands of cases, and that's something that will just take time from a different approach. But I think that's something, it does take a commitment to doing a lot to get good at anything, especially a new surgical approach. Aside from cosmesis, what are the benefits that you've seen and that we're finding out that happen for patients when it comes to vNOTES, and maybe also for physicians?
Mm. So the obvious thing is we're making no abdominal incision. So, aesthetically, I think for us as surgeons, that's a minor argument. I think we deal with a special population. We're just dealing with women, not with men. So I think in our population, it's more important than in the general population. I mean, we notice amongst patients, as a man, I have a knee injury and I'm in the locker room playing basketball and I can show my big scars to my mates. I feel like a big man. But for the female population, it is more important not to have any scars. But I think for us as surgeons, that's not a major argument when we're actually deciding which procedure to choose, and we want to choose the safest procedure for our patient. I think we've done 2 randomized controlled trials comparing vNOTES with laparoscopy, one the Halon trial for hysterectomy and a second one notable trial for adnexectomy, where we did in a single center blinded setting, a non-inferiority blinded setting. We compared the 2 techniques, and the clear significant outcomes were, well, one, it was a non-inferiority trial, so it was non-inferior. We had no more conversions in either group, but I think the more important ones was pain. So the postoperative pain scores were lower in the vNOTES groups, and the use of analgesia was lower. We had shorter hospitalization time, and one of the outcomes was discharge within 12 hours. And that was significantly higher in the vNOTES group than in the laparoscopy group. And we had lower complication rates in the hysterectomy group as well. But that's, single surgeon, single setting. So we're looking now we're starting a multi-center randomized control trial comparing vNOTES hysterectomy techniques, so laparoscopic hysterectomy, vNOTES hysterectomy, and vaginal hysterectomy. There's no good comparisons at the moment between vaginal hysterectomy and vNOTES.
It doesn't sound like an easy study to do, first of all, just being big and multi-center, but luckily, vaginal hysterectomy and laparoscopic hysterectomies are safe surgeries and have traditionally pretty low complication rates. And so, I imagine non-inferiority is probably easier to do than true benefit, but the fact that they're all pretty safe surgeries is a great thing, but to be able to introduce a new technique and show that it's as safe and also potentially providing some improvements like decreased pain is pretty amazing for a comparison against already pretty safe and well-tolerated procedures. So that's exciting. There are things I think about with improvements, though. So in Kentucky, where I work, we have a large percentage of obese patients, probably a lot more so than in Europe. Are there benefits outside of pain and hospital length of stay for vNOTES? I think about there are patients that I just cannot operate on laparoscopically for hysterectomy because their BMI is high enough that I can't get them in steep enough T-berg to see into their pelvis. Is that an opportunity, or is that still a limitation for vNOTES?
Yeah, I think you make a good point. I think there's just 3 groups of patients that benefit specifically from vNOTES, and the obese is one of them. I'll elaborate just now. I think the other group is the patients with previous abdominal surgery. Patients have had multiple laparotomies with mesogastric low abdominal adhesions. When you address those laparoscopically, you start with an adhesiolysis. When you do them endoscopically, transvaginally via vNOTES, you can often stay below the adhesions and don't need to do an adhesiolysis. So that's a group that definitely benefits. The second group is the patient with a very large uterus. When we do a hysterectomy for a large uterus laparoscopically, we're using a manipulator. We're pushing the uterus upwards to be away from the ureters. But that way, we're always pushing the uterus towards the camera, and we have to put our camera higher and higher or more lateral. And that's a group where vNOTES is particularly good because with vNOTES, you're pushing the specimen away from your camera, you're pushing it into the abdomen, and you're actually not working in the direction of your dangerous structures of the ureter and the bladder. You're working away from them. You automatically have your blood supply at the start of the procedure as well. So I think that's where you gain most with vNOTES is on those large uteri. But the third group that benefits a lot is the obese patients. Any procedure or with any technique is more challenging as the BMI goes up. And it's the same for vNOTES. A vNOTES hysterectomy on a BMI 50 is a lot harder than one on a BMI 25, for sure. But I think the degree of difficulty doesn't go up as much as it does laparoscopically. If you're operating a very high BMI patient laparoscopically or robotically, your distance to your specimen increases with the BMI. So you're using endoscopic instruments, but your pivot point gets a lot further away from your specimen in laparoscopy, and that makes it hard. In vNOTES, the abdominal wall is as obese in the patient, but the distance to your specimen vaginally doesn't increase. There's more abdominal fat, and it's going to be in the way, and it's going to be harder with Trendelenburg, but at least your distance to your specimen from your instrument to the uterus transvaginally doesn't increase. And patients don't tend to have as much adipose tissue vaginally as they have in the abdominal wall. So I think if I have a very obese patient, and you're right, we don't have those super high BMI 70 plus, I don't see those. But with experience up to 55, 57, I noticed that it's easier to operate them via vNOTES than laparoscopically. So I never doubt if I have a high BMI patient. I know there's groups in the US that have experience with BMI 70 plus and say the same. On those patients, they prefer to do vNOTES than laparoscopy. But of course, it gets more difficult. It always does.
Are there specific techniques? I think about the bowel. There's two things, I guess, with the patients that are obese. Getting in, certainly is a challenge, but I typically can find ways to get in things like Palmer's point, where there's usually an opportunity to do that and get a pneumoperitoneum. But it's putting a patient upside down, right? We're not dealing with the same challenges as the bariatric surgeons who are operating in the upper abdomen. So when they are operating, their patients are in reverse Trendelenburg, and all of their bowel get to go down, and there's decreased pressure on their chest. And so those patients, they're not getting as many complaints from the anesthesiologist saying, I can't breathe this patient, where in laparoscopy for gynecologic surgery, our patients are on their heads and we get them in much T-Berg, and it's like, guys, we can't do this. And so T-Berg is what, as you know, allows us to get the bowel up and out of the pelvis so we can operate safely. Is the degree of Trendelenburg required for vNOTES? Do you still have to put them upside down, or are you able to use less Trendelenburg? And then in terms of your peritoneum, is it similar pressures for vNOTES?
I think on a standard case, we use the same degree of Trendelenburg. We use 20, 25 degrees for the endoscopic part. There's a vaginal part as well where the patient's flat, so it's a shorter term of the procedure that they need to be in Trendelenburg. But standard, we use the same degree of Trendelenburg. We use lower pressures for vNOTES. So laparoscopically, we'll traditionally work 12 to 15. I mean, I think that's very much a local habit, and you could work lower, but that's what we have in our practice. And for vNOTES, we standard work at 8 to 10. I think that's really a collaboration with your anesthesiologist. The more they relax the patient, the lower pressure you can work on. I think for the very obese patients, we need to give them Trendelenburg as well, and that's always a balance. It's the same with vNOTES. You need to find that balance with your anesthesiologist. The pressures are a bit lower, and even then, we tend to try and give even lower pressures. I know for the super high BMI patients, that you can also try and pack the bowels. Vaginally, you have access to put a big swab in and pack the bowel out the way. I think for most cases, we try and avoid doing that. And I think I only do it for the very high BMI because, you pack, you dry out your bowels, you get more adhesion. So we try and avoid that in general. But on those challenging cases, that can help as well. I think another thing for our endometrial cancer patients, which is typically the very high BMI population, there with vNOTES, we're now doing our sentinel nodes retroperitoneally. And that really helps because as long as you're doing them transvaginally, retroperitoneally, but there you don't need any Trendelenburg at all because you're working retroperitoneal. So for that whole part of the procedure where if you're doing it laparoscopically, robotically, your patient's upside down already, with vNOTES, the patient's flat. And it's only for the small endoscopic part of the hysterectomy, which is actually the smaller part of the oncologic procedure, that the patient needs to go in Trendelenburg. But the majority of the time for both sides, the sentinel node, the patient's still flat on the table. So I think there's an advantage as well. I think I want to say for oncology, we don't have a lot of evidence yet. So that's all still in study settings.
So talk me through that. You're doing this lymph node dissection primarily prior to the hysterectomy.
Correct. Yeah.
And you're getting into the retroperitoneal space prior to getting access to the peritoneal space?
Correct. So we inject ICG into the cervix, as you would do for any case. And then we make our way transvaginally into the retroperitoneal space, actually to the obturator area, to the place where your obturator nerve exits the pelvis at the level of the obturator muscle. And then from there, you start your dissection caudally to cranially down to upwards. And actually, the CO2 does most of the dissection for you. It opens the space up. I think besides the fact that it's less invasive and your patient's flat, another advantage is that you follow the sentinel node as it is distributed naturally, the ICG, you go down to up. Whereas if we come laparoscopically from above, we see a green node and you may get excited and say, oh, I've got the sentinel node, I'm going to take this one out. But you got to be careful not to take the second or the third node because that can be green by the time you come already as well. Whereas in vNOTES, you don't have that risk. You come from the bottom, the first green node you see is automatically the sentinel node. So I think that's an advantage that in time with more studies, there will be a good place for vNOTES in that group, I think.
And that's done posteriorly initially with the access for the node dissection? Is that
there's two routes of dissection. Initially we started like a Schauter incision, which is a lateral vaginal fornix incision, and then dissected the paravesical space. It works. It's a bit more difficult to teach that access. So now we're actually moving to an anterior vaginal wall incision, similar to what you do for an anterior repair, and do the dissection from there. And we found that it's easier to teach that access to people who don't have Schauter experience. So it's like you're doing an anterior repair. You just go a little bit more lateral and you jump over the arcus tendineus, and then you get into the right space paravesically.
It just sounds like you guys are almost, as much as you guys have done, it sounds like it's just tip of the iceberg right now for what's possible with vNOTES. It sounds like there's a lot of potential.
I think what we see is we just get different anatomical access now. And the more vNOTES we do, it's a gradual process. It's been over 10 years. I've done over 2,500 cases. So it's not something you do in the beginning, but you learn your anatomy in a different way. And we actually get to spaces that are difficult to reach laparoscopically. We're doing promontory fixations via vNOTES in urogyn as well now. And that presacral space, the dissection there, you're seeing structures that I've never seen before laparoscopically, just because we're coming in from a different angle. So there's definitely a lot of room for development in vNOTES still. And I think the most exciting thing is that we just, we see our anatomy transvaginally in a very different way, and we get to reach different places.
And that's something I noticed just even doing just the training and watching videos is, again, as I mentioned earlier, so much of what we do is visual cues. Is like, okay, I need to see the ring, our colpotomy ring as we're pushing up. I need to sort of see that full ring, my posterior dissection, anterior dissection, always opening all those spaces up, skeletonizing completely, all those things. Big uterus, little uterus, 10 C-sections, doesn't matter. I want these same views. I want these same visual cues so I can understand where I am and where my anatomy is and where I can operate safely. And that develops over time. When you start out, you're taking little bites, and as you get further along, you're like where you can be a little more, I won't say aggressive, but a little bit more comfortable versus where you really need to kind of dial things in. And that's something that seems like it just takes years, which is what surgery is. But to develop an entire new approach to surgery, I think, and I'll again speak for myself, I think it's very intimidating to think about jumping into a new approach like that. Is it something that, are you seeing it being taught in residency? Because again, if we're teaching our residents, our trainees primarily to get comfortable that way, then it becomes a shift in how we practice as opposed to just a few select surgeons around the country.
You make a very good point. I think the key to a safe implementation is standardization and good teaching. And I think that's what we've been trying to focus on most, is to really get the technique standardized, because the more standardized it is, the less room of variation there is in people in their learning curve, and the lower the learning curve is going to be. And then it's proper training. And I think that's where, you mentioned them, applied medical's helped us a lot with those standardized training courses. We now give exactly the same training courses all over Europe, all over the US, in many other countries, and in Australia. And it's all a standardized content. It's exactly the same presentations. It's exactly the same steps. And I think that will really help in keeping our complication rates down. It is something that worries me, because most techniques go through that Gartner cycle, where it takes a long time in the beginning to get the adoption going. And then, all of a sudden there's a lot of excitement about the technique, and a lot of people get started, and not everyone necessarily goes through the right training steps. And you get a peak. A lot of cases get done, but then you get to a level where you start seeing the complications coming. And then there's going to be a bit of discredit to the technique, because there's going to be reports on complications. And at that point, we're going to need the evidence to prove that in the hands of people who've been properly trained in a standardized way, this is what our complication rates are, and they are not higher than they are in standard other techniques. And I think that's where the studies are important, and where the big complication or case registry, the International Node Society has a big case registry that's been going since 2015, where a lot of surgeons put their data in, and there we'll be able to see now what actually the complication rates are in the hands of experienced surgeons. And hopefully, when that dip comes and the complications start coming in people who haven't gone through the proper training, that's what will help us defend the technique. Because what we see in the studies is that the complication rates are not higher than in other techniques, if not even a bit lower. So I think that's the job for science now, to get the technique established.
What are specific complications? What are complications that are unique to vNOTES? Because as I think about going through and doing a hysterectomy laparoscopically, I have the same steps. Every case is the same. Again, doesn't matter on the uterus. It's just like always the same steps, just different amounts of time spent on each one. But with my uterines, taking them more medially, so if it retracts, I've got a nice pedicle. Like, how do you chase a pedicle laterally outside of the ring and those kinds of things? What are specific challenges and complications that one can expect when starting to introduce vNOTES into your practice?
I think what you say on the uterine artery is really important there, because obviously bleeding is our most common complication in all procedures we do, all techniques. I think specifically to vNOTES, you get, we're talking hysterectomy now, if you take the uterine artery, you get it right at the start of the case, not at the end of the case, and without going retroperitoneal. So that's a benefit. But a downside is that if you don't seal it properly and you cut it, it will retract behind the alexis ring, and then it becomes more challenging to catch it. Now, if that happens, we take the ring out, you pull on your pedicle, on your uterosacral pedicle, and then you can grab it vaginally. But that's a moment where you need some vaginal experience to grab that. I think the main thing we always stress in teaching is that just take your time for that uterine artery, and don't just take it once with a sealing device and be confident with it. It will work 9 out of 10 or 98 out of 100. But there will be a couple of cases on a larger uterus where you're putting more traction, where that is not enough of a seal. So, take it a couple of times next to each other with your sealing device or with a standard bipolar before you cut it. Take your time on that uterine artery, and then it's never an issue. And also, once you've done that, the rest of your hemostasis is easier. Then you can speed up and don't need to worry so much.
I imagine the ring provides some hemostasis a little bit on the little stuff too. When I think about our transvaginal tissue extraction, when we put the ring in, put the bag in, it's putting significant pressure on the vaginal cuff for the time that we're doing our morcellation. When you go back up above and close the cuff, there's been like somebody holding pressure circumferentially for whether it's 10 minutes or an hour and a half, depending on the uterus. You're providing some hemostasis. Does the ring itself provide some additional hemostasis and vNOTES in the same way?
It does. It's exactly like you say, it compresses, but once you take it off, you have to check your hemostasis again. I think a second thing that it does is it lateralizes your ureter. And we did some cadaver study to look at that. But because that alexis ring pushes on the pelvic sidewall, it automatically pushes your ureter more lateral. And we saw when we did the dissection without the alexis in place, we sort of had, 2 inches between the pelvic sidewall and then a natural position of the ureter. And when we put the ring in place, that reduced to 1 inch. So it lateralizes your ureter about an inch. And that I think helps. And I think that's what we've seen in the studies that have been published so far, is that we have less ureteric injuries than in laparoscopic surgery or laparoscopic hysterectomy. But we have a slightly higher rate of cystotomy. And I think it makes sense because, you're doing that dissection vaginally.
That's what we all fear. That's what we all fear, is doing that colpotomy, is getting in from above or from below. I think that's the kind of thing that with time, I think that rate will go down, but you just have to understand there are trade-offs.
That is the one to be aware of. I think it's logical that our cystotomy rates are a little bit higher in the vNOTES studies than in the conventional vaginal hysterectomy studies, because we're tackling more challenging cases. We're doing bigger uteri and bigger myomas and multiple C-sections. I think what helps there is, but this is now very technical, but I'll stay brief, is that instead of making your colpotomy as you do on a vaginal hysterectomy, just with cold scissors and a forceps, is to actually make it endoscopically. So you can place your inner alexis ring in a way that it is between the vaginal mucosa and the still closed peritoneum. And then you can make your dissection for your anterior colpotomy with endoscopic instruments. And I think with that, we now see that our cystotomy rates are going down.
So I saw that on a video, because I think about patients had 2 or 3 or 4 C-sections, and there's going to be some scarring in the lower uterine segment. but there's always that safe space between the scar from the cesarean and your uterine arteries, right? Because most of us, if we're doing C-sections, and I haven't done one in a while, but I'm pretty sure they still try to avoid the uterine arteries. And so when they're closing your hysterotomy, from the C-section and scarring, there's always that little window, that little safe window just anteriorly. So even if your uterus is plastered to the anterior abdominal wall, dissect posteriorly, jump over the uterines, and just bluntly just push whatever's there and just isolate your uterines. I watched a video as part of the training and could see it vaginally, where they placed the ring, not because they hadn't made their colpotomy yet, placed it up against that C-section scar and blew it up. And you could see that black, dark, because it was insufflated from the posterior colpotomy. So that black, thin, single layer of peritoneum, you could see your uterines that you'd already gotten or were going to get on the lateral aspect. But just anterior to that, I could see the backside of that. And it was a very light bulb moment for me. I was like, there it is. That's the spot. We found, again, I found it on the other side. It took me seeing it to realize what it was. And all of a sudden you go, okay, officially I get it now. I can sort of imagine how once you find those opportunities, because there's like any surgery, you just, where are your safe spaces? Where are your opportunities for success? I saw that and go, okay, now that makes so much more sense. There's a completely safe space. I can just see it clear as day. And so again, that was a moment for me where I thought vNOTES was pretty cool.
Yeah. You describe it beautifully. I can't describe it any nicer than you did, but that was exactly what I felt the very first time I tried it. Because I thought, how can I try and reduce this rate? Can I place the ring? And tried all sorts of setups. And then when the first time we put the ring that way and saw that, it was like, but now we can do these difficult colpotomies where in a normal vaginal hysterectomy, you're stuck. You can make your posterior colpotomy, tie off the uterosacrals, but if you can't make an anterior colpotomy, you have to convert to laparoscopy. But now, yeah.
And in a vaginal hysterectomy, you're pulling the uterus down, you're compressing that tissue, you are making it more difficult. And what they keep stressing was push that uterus away, push the uterus away, push the uterus away. Just like you're doing from below with the colpotomy cup laparoscopically, you're doing it yourself. And by pushing it away, you're exposing those windows to allow you to visualize those small spaces much, much more largely.
Exactly. And you have a double flow of carbon dioxide. You have your flow that goes behind the uterus and opens the space in the abdomen. And because you have that empty space there, as you describe it, it's blue or black, the peritoneum, because there's nothing behind. And where your bladder is, it's actually white. It's not. There is something behind it. So that really, really helps. And if it's one of those uteri that's plastered to the abdominal wall, you can basically do your whole hysterectomy and just leave the uterus hanging on the C-section scar. And at the end, you shave the scar like you shave endometriosis.
And that's the same way we do it laparoscopically. I mean, I think many of us, when we first get in there, when you're doing an abdominal hysterectomy in training, that's where you start, because that's where your abdominal incision is right on top of the mess, is right in the scar. And when you get in laparoscopically, and you learn that's the last thing we do. If you see someone start chipping away at the scar first, it's like, whoa, stop. Let's get all the blood supply, and then we have a little dead uterus we can chip away. Seeing that done from below with the camera was pretty exciting. I thought that was pretty neat. I think the other thing I was trying to visualize that will take some time is the ureters, because as we have that ring in, the bladder's anterior to us. The ureters are coming in lateral. The ring, like you said, it pushes it out of the way completely, right? They're just, once you've gotten your uterines first, I imagine the ureters are just now nowhere near. Not that you ever ignore them, but they're nowhere near where we're operating once the uterines are taken.
I think the moment when you're closest to your ureter is when you're coagulating uterine artery. And that's actually the only moment when you're close to it if there's no endometriosis and they're in the normal position. The whole bend of the ureter into the bladder is behind the plastic sheet. And I think laparoscopically, where we have our ureteric injuries is not where we go and dissect it to find it. It's usually when we coagulate too close to the vaginal cuff. It's right where the ureter goes into the bladder, the point where you normally don't even dissect it laparoscopically. And that area is protected by the Alexis sheet, and then the ureter at the level of the uterine artery is lateralized a bit because of the pressure of the ring.
So talk to me. You mentioned endometriosis. Talk to me a little bit about how you address. Again, I think the bigger uteruses, we've talked about that a little bit as well. But things like endometriosis or pelvic scarring. How does that change your approach to vNOTES? I mean, are you addressing stage 4 endo with vNOTES these days? Are there certain cases where you're just like, this is just not appropriate? Like, how do you address that?
What we teach is that endo is a contraindication for vNOTES. And I think there's no need to be dogmatic about vNOTES. We got to think where our patient benefits most of the technique. And I think some patients will be better off with vNOTES, some will be better off with a laparoscopy, some may be better off vaginally, some may be better off with a robot or an abdominal hysterectomy. I think we need to master the technique so we can tailor them to the patient's needs and not try and squeeze every patient into one little box. So I think there's no reason to do a case where you worry about a posterior colpotomy, whether it's going to be safe or not. If you even have that thought, you should put in the scope and just make sure it's safe. So I think from that point of view, we always teach that endometriosis is a contraindication, previous rectal surgery is a contraindication, patients who've had pelvic abscesses, severe PIDs where you don't know what your Parcher Douglas is going to be like is a contraindication. That being said, in research, we try and check where the boundaries are and where vNOTES can lead us. And I do think with the increased visualization that it gives us, there is in time going to be a space for it in more complex procedures. We're starting doing radical hysterectomies for cervical cancer now as well. And it's an amazing visualization you get. I've done a number of rectovaginal endometriosis cases, but that's not something that I like to talk about in teaching. It's just a whole lot more challenging, and you need to be very familiar with vNOTES anatomy before you go there. So I think the short message is just don't go there. It's not necessary. Just keep it safe and do it laparoscopically.
Yeah, not easy laparoscopically either, obviously. But I think again, as I'm thinking about the anterior challenges, like are there potential benefits from below? Maybe if you can address the nodule and feel it, you can work around it, start laterally. I can see where in the hands of a skilled vNOTES surgeon who's been doing this a long time, are there potential benefits? And that'll be interesting to see develop over time.
Again, you make a really good point. You see the details very well. That's exactly what we're trying to do now in research is we're trying to do a combined approach where we operate endoscopically, laparoscopically, and vNOTES with two surgeons at the same time for radical endo, because what is the most difficult is from above is the lower part. If the nodule's low down on the rectum, halfway the vagina, it's difficult. If you come from below, that part's not difficult endoscopically. It gets more difficult as you get higher and higher. And if you use the best of both worlds, you can meet each other in the middle. So that's what we're trying now. We've just made our first publications on that. But I think that's far away from being routine.
But I think the opportunity is there. There's definitely times when you want to go, what's behind there? I think if it's clear behind there, then we're good. But the potential to do both, and that's something I've thought about as I try to visualize my first cases and visualize like how I would do these, popping a scope in from above and watching myself entering in and seeing where I am. So I can match my vaginal procedures to my laparoscopic visual cues. Is that something that you recommend?
I think that's a fantastic way to keep your learning curve safe, is any moment where you doubt in your entry, put in a 5mm scope in the umbilicus. The patient won't mind. They'll barely see the scar. And you'll see what you're doing, and someone can hold the camera from above while you're operating from below. And like that, you safely build up your confidence in your implementation. I think it's a fantastic way to start. Yeah.
Let's talk about non-hysterectomy surgeries briefly as we get sort of towards the end here. I think when doing laparoscopy, we always say like 5s are free. Like I hate putting 10s in. I never use 10s for any of my surgeries, 10mm or larger ports, because I don't want to close fascia. I want to minimize my hernia rates. Single site you mentioned, I am not a fan. I think those 2 to 3 centimeter umbilical incisions have such a high hernia rate. If I'm morcellating, I make a mini lap fan steel at the same size and do most of my morcellation that way, because the hernia rates from a fan steel, and we're, as obstetrician gynecologists, we are and should be confident making fan and steel incisions. They're great incisions to close. I try to avoid larger incisions in the abdomen all the time because of concern for hernia and also just pain. I mean, huge umbilical incisions, patients do not like those, and they don't like their belly buttons to be messed with. When performing a colpotomy for a single site vaginal incision, what are the hernia rates? I imagine the vaginal hysterectomy closures are the same as a TVH, but for a non-hysterectomy case, and you're doing a posterior colpotomy and doing a vNOTES for adnexal surgery, what are the risks of vaginal cuff, in a sense, dehiscence or vaginal colpotomy dehiscence or hernia rates for those surgeries?
Yeah. So for the listeners, for a hysterectomy, we make the same incision and we have the same scar, so that's it. If we're doing vNOTES for other indications, and as I said, we do it for the whole spectrum of gynae procedures, that's where we're going to need evidence to prove that it's safe, because with hysterectomy, we're reducing our number of scars or number of incisions. We're taking the abdominal incisions away and we're just keeping the vaginal incision. Now we're in adnexal or myomas or whatever. We're taking the abdominal incision away, but we're replacing it with a different incision. And, so there's your question very correctly. Are we not taking any other risks by putting an incision in a different location? I think what we noticed is that those incisions are less painful because the innervation to the vagina is different to the abdominal wall, so there's an advantage. As far as I know, in the database, there's no dehiscences described for a posterior colpotomy. We've had hematomas from the posterior colpotomy, but no dehiscence as far as I know. I haven't had any. I think the vaginal wall's very forgiving. We know that from obstetrics as well. It heals very well and it doesn't get infected as easily. The two big questions that we always get there is, one is, what about deliveries? If we do this on young patients for ectopic pregnancy routinely. And two, what about sexual intercourse? Are we causing dyspareunia for these patients? I think the answer for the first one is it's a worry in our head, because from endometriosis, many of us are in the habit, if we've had rectovaginal endometriosis, we've shaved the rectum and we've resected part of the vaginal wall. We tell our patients, have a cesarean section and not a vaginal delivery. I think it's different in vNOTES because we don't have that rectal shaving and we just have a scar in the colpotomy. I think the data that we have on vNOTES are limited. I think there's only one publication we've made. There, it's in personal experience. We've had lots of deliveries after vNOTES and have not seen any problems. I think scientifically we have data from specimen extraction studies, people who do adnexectomies and take the specimen out through the colpotomy, and those data also suggest that incision is safe for a vaginal delivery after that. So I think that's not an issue that I worry about, and we do it on young patients. I routinely do all the ectopic pregnancies that way. And we let them deliver vaginally, and our C-section rates or our tear rates are not higher. I think the dyspareunia is a much more important question to look at. And there we need to have big data, and there's studies ongoing on that. We have data from the RCTs that we've done, or the RCT on adnexectomy, that don't show any higher problem rates. But those are small data up to now. Again, very technical, but I'm going to try and explain it anyway. I think it's really important where you place that incision. If you make your posterior colpotomy incision on the same location where you would do it for a hysterectomy, the problem then becomes that your vaginal mucosa retracts a bit. And when you close it afterwards, you don't have a lot of mucosa between the cervix and your incision to close.
Right. I imagine if you're right up next to the uterus, which is where you want to be for a hyst, you don't have much with which to close.
Exactly. And what you do then is you actually pull your uterus into the posterior fornix. You pull your uterus backwards, and then you don't have a posterior fornix anymore, which could be a cause for dyspareunia. And that's something that I think is really an important issue to teach, is to where to place that incision. So for a non-hysterectomy case, your posterior colpotomy incision must be at least 1.5, 2 centimeters lower, closer to the rectum. But then your dissection has to be upwards. And then you have a lot of space to suture. But so you need to retrain that colpotomy from people who are used to making it for hysterectomy. You need to make it in a slightly different location. And then I think, from my experience, it's not a problem. I don't see any dyspareunia problems with that, but I make my incisions very low, far away from the cervix.
I've seen folks that do colpotomy for tissue extraction for like myomectomies, right? Patients who are going to get pregnant, patients who are at least planning on getting pregnant, who are wanting to get smaller abdominal incision. So for robotic or laparoscopic myomectomies, don't want to make that big incision, but you don't have a colpotomy or vaginal or colpotomy from a hysterectomy, but they're making a posterior colpotomy incision, and it seems like it works pretty well. How are you closing those? Are you just doing a barb suture single layer? Are you doing it in 2 layers? How do you close those incisions?
Single layer to vicryl I use, but probably whichever suture is probably not that relevant there. But we do single layer. I try and approximate peritoneum and vaginal mucosa together. because it's always it's that dissection space between the peritoneum and the mucosa is where your oozing is and where your risk for hematomas is. And if you can compress those two layers together, then, but I think whether you do that in a running suture or in separate figure of eights, it probably doesn't matter. I think it's very forgiving there.
I feel like I could ask another 100 questions about this. I know you're a busy surgeon and we're grateful you spent time. Any last thoughts for our listeners on vNOTES, on things that they should think about when introducing this into their surgical practices?
Yeah, I think go through the proper training pathways. They're available and they're available all over the world. I think you have listeners all over the world, but these courses are being given in the same way everywhere. What worries me most is people watching a YouTube video and thinking, I can do this. And it's not difficult surgery, but as with any technique, there's just lots of little tips and tricks, and surgery is always in the detail. And if somebody explains you all those details, it will just be so much safer for your introduction. And then the second thing, I think once you get started, is to start with the very, very easy cases. If you start with very easy cases, then you can gradually build it up. It will just be nicer. It will be safer for your patient. It'll be nicer for your whole team, because it's a new procedure, not just for yourself, but for your whole OR team, and you have to get them involved in the process. You have your scrub nurses and your anesthesiologist, and you have to get everyone involved in the process. And if you can then make sure that your first cases go smooth, you keep everybody motivated, and it's a safe and easy implementation. I think the problems we see is people who try to run before they can walk, and they start with a 800-gram uterus. That's not the way to start a new technique.
I think that's not different than what we see with our colleagues, whether they're trying to start laparoscopic surgery or jumping in, doing 2 to 3 hysterectomies a year and think, oh, we'll go ahead and just do this 1 kilo case. It's like, make sure I'm around for that one. Because I think like anything with surgery, it is repetition. It's everything, minimize variability. It is getting as many of these as you can, so you can start to see the subtle differences and nuances with anything. But yeah, it sounds like, though it's a new approach, old adages are true, and it's all about, developing techniques. Start easy and work your way up, and give yourself the space and patience and your whole team the time and energy. But starting with that training, and I can say from personal experience, having done the training, it's done really well. I mean, it definitely was important for us to do that. And as we start doing them where we are now, I think the reason we're going to have good outcomes is because of the training and because of the team that we've built, and the number of surgeons who are committed to helping all of us get better. Actually, one last question. I just thought of this as we're wrapping up. Robotic surgery, single site, anything. And is there any examples that you've used the robot with this stuff, that you're using any additional besides straight stick laparoscopy? I assume that's traditionally what you've done. Is that something that's being done, that's being talked about, using vNOTES in combination with robotic surgery?
Yes, yeah. There's a whole big topic. I think we can do a whole podcast session about that, but I'll keep it brief.
We'll have you back.
It's inviting myself. It's what I'm doing now. With the current existing systems, I tried a couple of years ago and looked with a Da Vinci Xi whether we could do vNOTES, and we did 30 or 40 cases. And it works. It's just there's no benefit. It's making life difficult. It's not made for it, and there's no space for the forearms. You can do it with 3, but there's a lot of arm collision. It just adds a lot of extra time to the patient and to the surgery, and no benefit. So I think there no, but I think there's a lot of development in robotics, and there's a lot of new systems coming. Single site system, you have the SP system from Intuitive. I work a bit with Momentous. They're developing a robot for transvaginal use specifically for vNOTES, and they're on the market. I'm in Europe, so it's not on the market here, but it isn't on the market in the US.
Is that the one that goes behind the uterus and looks up laparoscopically?
And retroflexes.
Yeah. I've seen that.
So again, I think we're going to need studies. We're going to need evidence, and it's going to be hard. vNOTES endoscopically is not that difficult, and our procedure times are getting so short compared to laparoscopy that to prove a robotic benefit to that is gonna take time. But I think it's going to be the same as with robotics transabdominally. We also don't have a lot of evidence yet, but there is a group of surgeons that feels more comfortable doing it that way. And then that's absolutely great, because that's better for the patient. And there'll be a group of surgeons that feels more confident doing it endoscopically, laparoscopically, or via vNOTES. And I think whichever technique gives you the most confidence to do it safely for your patient is the one that you should choose. So I think there'll be a place for it in time for sure. With development of more and more new robotic systems, it will come. But I think at the moment, it's for a specific niche.
I keep saying last question, but I didn't. As you say something, a new idea pops in my head. But maybe this will be the last question. We'll see. Ergonomically, it seems like, I've talked to general surgeons about this who, if they're doing upper abdominal surgery, they're standing in between the legs. They're operating, the normal, standing up straight. Laparoscopy in the pelvis, we're standing at an angle, we're leaning over no matter how well we set ourselves up. Are you sitting for these cases? Are you comfortable? This is like, it's just like you're sitting at a desk, like ergonomically more comfortable than in traditional laparoscopy?
It's a big difference. I mean, I operate 2.5 to 3 days a week. If you do a lot of laparoscopy, it takes a strain on your shoulders and on your neck. And with vNOTES, I said our surgical times are shorter. We're taking in the studies half an hour off our hysterectomy times with vNOTES, so your procedure's shorter. But you're also sitting, you're not standing up, and you're sitting with the screen straight in front of you. Your shoulders are close to you, and you're more comfortable. So it definitely makes a big difference.
I have no problem being more comfortable. At the end of a long day in the OR, my shoulders are definitely letting me know more and more these days that they would be happy if I found a more ergonomic way for me to do these cases. So on that note, I think we'll in respecting your time, we are so grateful that you were able to join us today. That was fascinating. And I look forward to seeing all the great work that you'll continue to do. You don't have to invite yourself. We'd be happy to have you on any day and chat about what you're doing, new things that you're up to, advances in vNOTES.
Thank you. Sounds interesting.
Wonderful. All right.
Thank you so much for having me. It's been my pleasure.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Taylor's Version Hess and Ivan Orvijinsky.
Show notes and social media by Jody Lenora.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time.